Can you hear me? It's not on? It's not very loud. No. I don't think it's on. Hello? There we go. Hi, everybody. We are now doing Ivf Protocols. Can we all take a seat? All right. As a founding partner of Southern California Reproductive Center, Dr. Gadir is a double board certified in both obstetrics and gynecology, as well as reproductive endocrinology and infertility. A very popular, approachable, and well-liked fertility specialist, Dr. Gadir's expertise has been featured nationally and internationally in the Los Angeles Times, Red Book, People Magazine, Beverly Hills Weekly, Antelope Valley Press, Fox News, ABC, BBC, and much more. He has not only been listed among Los Angeles Magazine's 2014 Super Doctors, but also named Altruist of the Year by Datebook Los Angeles. More than his strong work ethic, Dr. Gadir has built a reputation as a compassionate, responsive, and hand-holding physician. A strong believer in preparing for the future, he is committed to helping patients retain their future fertility options, whether it is an egg freezing, embryo freezing, or preparing for medical treatments that can affect reproduction, such as chemotherapy.
Whoever wrote that bio, thank you very much. It sounded good. I'm Shaheen Gadir. I work with Southern California Reproductive Center. We are one of the largest IVF centers on the west coast of the United States. I want to welcome everybody today. Can everyone hear me? Yeah? Okay, great. So today we're going to be talking about medicated and natural IVF and embryo transfers. So natural way versus a medicated way. What are the benefits of it? What are the options right now? We have a lot of options. That's the good thing about where we are in the field of fertility, that there are a lot of options that work for different people. And we want to make sure that what you're getting done is going to be the perfect option for you. We're going to talk a little bit about the background of IVF and everything we're doing. We're talking a little bit about the natural versus the medicated IVF cycle, and also about the embryo transfer cycle. Please feel free to interrupt if you have questions in the middle. The pictures look a little formal, but I want to keep this as casual as possible and make sure that everyone's questions are answered. So natural conception rates, as we know, is that with the more number of cycles and as it moves on and on, the success rates may be going down. So most people are getting pregnant earlier on, and as it moves on and on and on, with more and more attempts, the chances of successfully conceiving kind of go down, unfortunately. And many of these reasons have been summarized in this little chart here. There are reasons that have to do purely with the female. There are some reasons that have to do with the male. There are some that we're noticing more and more and more that it's a combined effort of issues that are causing difficulty conceiving. And of course, the most frustrating is the unexplained area of fertility, that we just don't know why people aren't getting pregnant and having implantation, and whether it's a uterine problem or an egg problem or a sperm problem, sometimes surrogacy is definitely the answer. So there's a different population of patients that we believe do better with one way or another. So the natural IVF cycle, the method and who it's good for is not for everyone. And exactly the opposite, the medicated form is, better for some people. And I'm going to start by letting everyone know that I have a true bias, and it's going to come across as I present this. But I do believe that with the technology that we have available in the world of fertility, and everything that some of my colleagues in the world of fertility and ourselves are doing, with the things that we are capable of doing for patients these days in the medicated world, and giving you a great chance of making a good number of eggs, a completely controlled cycle that we do very well, having control of when things happen, may be a better way for people. But I do know that there are people for multiple reasons that don't want the medications, don't want to have a lot of eggs, don't want to make a ton of embryos, and that's why we're presenting this information today. So for the natural cycle, basically you need to be in good health, you need to have younger, good quality eggs, You need to have not been trying to conceive for a super long time, and I think knowing that you have a good potential, you could be a good potential candidate for going the natural way. Those patients need to have regular cycles, and these are things that occur and can be very useful, especially for same-sex couples as well, that just have a tiny little bump of getting either a sperm or egg in the picture. The medicated cycle obviously works for everyone who wants to go that route. For our patients that are under the age of 35, we believe that after 1 year of attempting, it's time to move on. And for patients over the age of 35, trying to conceive for about 6 months is usually the guideline before we want to intervene and help and make this happen sooner than later. Whether a patient has regular menstrual cycles and is ovulating monthly or is not, it's either way is perfectly fine with the medicated route. These are for good prognosis patients. These are patients that we think are going to do well when we give them some medications. And for that reason, if you are a good prognosis patient, giving you a little bit of medication will make you a better prognosis patient. Male factor infertility, and also, unfortunately for cancer patients, giving them some medicine to get as many eggs out as possible, and giving more opportunity for the sperm that we do have available can go into more eggs gives you a better chance of success. And obviously for our same-sex couples, giving medications to an egg donor to make as many healthy eggs as possible, giving them the most number of embryos and the most opportunities of being pregnant in the future is very helpful. So the natural IVF cycle, unfortunately, does have a lower pregnancy rate. We don't have a lot of eggs to work with. We don't have a lot of embryos to work with. So the fewer you have, the lower are going to be your chances of success. And there's a huge number of cancellation cycles because we're giving less medication, so we have less control of when ovulation occurs, and sometimes we miss ovulation. And for that reason, the cancellation of these cycles is very high. The patient must have normal ovulation, or else it's almost impossible to get a healthy, good egg from that patient. And for poor responders, that are those patients that when we give a lot of medications to, or even a decent amount of medication, and still don't make a lot of eggs, this may be a perfect candidate for the natural cycle, because they're going to make that one egg on their own. So why spend all that money, all that time, all that energy in giving them hormones and shots when they're going to still make just the same amount of eggs? So that's a patient that I would encourage potentially discussing the natural cycle. There are lower rates of multiple gestations, obviously, because we have fewer embryos that we're dealing with. There's less monitoring. It can be less costly, but I say that with a lot of hesitation because it's less costly, but you're getting much less out of it. So you got to look at that very, very carefully. Patients who do not want to tolerate hormonal stimulation or don't have a choice, this may be the only route of trying to get an egg out. And also, we do have patients that morally are just against having more than one embryo created at a time. But I will jump to the other scenario, is that if we do get more than one egg from a patient that is morally against making more than one embryo at a time, we do freeze eggs and take one egg at a time to make the embryos. So again, the medicated route may not be so bad for that patient as well. The age distribution of patients, as you can see, the purple is the natural cycle. When you're younger, the stimulated cycle, which is in the blue, does much, much better. But as you get older, your chance of success is going to go lower for the stimulated and higher for the natural cycles here. And it's completely the opposite for younger women. The utilization of natural cycles in the United States, it was very, very hard to find some of this information, but after doing some research, is very low. In 2000, the data, I couldn't find any newer data, but 2006, there was only less than 1% for both 2006 and 2007 of patients that did IVF with the natural cycle without medications. So the natural cycle versus the medicated cycle, it depends how you like to eat your fruit, okay? So if you want to just have one apple and put all of everything into that one apple, going for that cycle without injections, without gonadotropins is going to give you that. I'm, like I said earlier, the kind of person that wants to have a lot of cherries, because you never know when you're going to get that good cherry, when you're going to get that soft one, when you're going to get the perfect one. More options, better. I just think having more options, going down the route, which is the more typical way, the way to get the most number to give you the best opportunity and the best chance with the medicated version, I think is, in my opinion, shown in this picture and kind of showing where I think there's going to be some benefit with more opportunities right here. So the natural cycle involves monitoring, but with no medication. So the patient comes in, we monitor to make sure that little egg that's going to get bigger and bigger, and then once it's released, we catch it. It starts off in the beginning of the cycle, looking at the eggs and seeing what's going to begin to grow. We bring the patient in for blood tests and ultrasound around day 10, where an egg is getting ready, but not quite ready. And sometime around day like 12 or 13, again, we're going to see what's going on. We can give an injection called Lupron to keep the patient from ovulating, if the patient is willing to take that injection. And then a couple days later, usually around day 12, when ovulation would occur on its own, the egg is going to be retrieved under a light amount of anesthesia. And we do that in our surgery center. And it takes a couple of minutes at the most. Now, the medicated one, when I saw the slide, I got freaked out myself. But there are benefits to everything that everyone has to do, okay? So everyone knows the harder you work on something, there's, the more difficult things in life sometimes have the most amazing outcomes. And this is a scary looking slide. I don't know whoever made it. I would never have wanted to use it, but to get the point across, it's here. As everyone, if you do know or you do not know, I just want to make it real clear. I had to do IVF with my wife, and she passes out when she sees a needle. And she did not pass out. These needles are extremely small, to the point that she would be like, "Did you give it? Did you give it?" I'm like, "I gave it. It's already done." Like, she wouldn't even feel it sometimes. So the needles are really small. And I'm sorry it's not depicted in this picture with these needles that are like 3 inches long. But basically, the way that normally works, a conventional cycle begins on day 3 of a cycle. It usually involves about 10 to 12 days of injections. Sometimes it's a couple injections. If some people need extra medications to help with quality, you have an additional one, but it's usually about 3 small little injections a day. And sometime around day 14, with a vaginal procedure that's under anesthesia, the eggs are retrieved through a special little ultrasound guided needle aspiration, we call it. A needle goes in and it kind of sucks out all these eggs. Usually people wake up 5-10 minutes later, they don't feel anything, they didn't even know anything happened, usually we get as many eggs as we can at that time, and we're ready to move forward. So at that time, we are able to then do whatever we need to, for example, getting the sperm into the egg. The ICSI, which is the intracytoplasmic sperm injection, is when we have sperm that needs to be injected into the egg, versus when we put the egg and sperm together and let them do their own thing. In these two situations, we would discuss beforehand and let you guys know what we think would be the best way to proceed, and then we would watch the embryos grow. We generally watch the embryos go to the blastocyst stage, and that's the stage when the embryo has grown for about 5 or 6 days, making it fully grown outside the body. And at that point, we would decide if we're going to do a biopsy on it to do genetic testing, which I highly encourage people to do, or if we're just going to freeze them for a future transfer or put them into a surrogate or into a patient at that time. Now, the success rates for the natural cycles are also by far lower. Unfortunately, you have less to work with, so you have lower success rates, and the success rates and live birth rates are lower, by far lower. As Dr. Donishmand was saying, some of our success rates in these categories using egg donors and using surrogates were in the 80 to 90 percentiles, and those are very different than these success rates that don't even hit the 20 percentile. Now, the natural cycle embryo transfer is something that's very different and something that we actually do for many patients and has done very well. So once you have a lot of embryos, ideally, whether it's the medicated or the few embryos with a natural cycle, you have different ways of putting it back into someone. We have the way of doing it and controlling it, which is a medicated embryo transfer, which we would give some injections to keep the surrogate or the mom from ovulating. And at that point, when the lining looks beautiful like it does in this picture, this is the lining, and we measure from here to here. It has like a triple layer, one on the top, one in the middle, and one on the bottom. At this point would be a perfect time to introduce the embryo. It comes in, it's released. We do this under 2D, 3D, and 4D ultrasound in our office to make sure we have the exact appropriate location. There's a way of doing this without having to use a lot of medications as well, and that's what we call a natural cycle. It would be for someone who makes a beautiful lining on their own every single month. We would monitor, and at the right time of the month, just like this, we would then put an embryo in without really needing to use a lot of medications. It really involves some careful monitoring so you know exactly when the ovulation is occurring from the person who's making the lining. When you're using the medicated version of doing this, you have a little bit more control, a little bit more flexibility. But either way, in this situation, and if it doesn't work sometimes for one with a medicated, we sometimes switch to a natural, and it can do extremely, extremely well in both circumstances here. The medicated frozen embryo transfer is a little bit more involved, but again, gives us a little bit more control. It starts generally with a short course of birth control, and then an injection called Lupron, which keeps the person from ovulating. And then there's estrogen pills that people take, and we usually start off by taking, 1, then it goes up to 2, then it goes up to 3. It makes that lining of the uterus look good, and right when you think the lining looks great, we kind of fool the body into giving it progesterone. And depending on if it's, for example, a 5-day-old embryo frozen, we give 5 days of progesterone, so it's ready for the embryo going back inside, and then this is when the embryo transfer will occur. So one of the things we like to encourage patients is the idea of doing a single embryo transfer. Our success rates are rather high, and putting 2 in is going to really increase your chances of having 2. I'm a parent of 1 child, then I'm a parent of twins, so I can tell you it is very, very different. I love my twins to death. It was the best thing that ever happened to us, but you have to be prepared and know what you're getting yourself into. If someone is willing to do everything that I have done, the nights and the days and everything else, including the weekends and soccer practice that I missed today for 2 people at 2 different times, it's an amazing thing, and we encourage people to do it. But it's something that is going to involve a very clear discussion and making sure that putting 1 embryo or 2, which is best, but our goal is always a healthy pregnancy and a healthy delivery of a child, and this is achieved in many ways with 1 embryo transfer. And I think that was the end. But I am happy to answer any questions about those things or anything else that's related to our field that I may not have particularly been addressing today. Yes?
Yeah, why do you encourage genetic testing, knowing that biopsy could cause 5% loss?
So in our IVF lab, we definitely do not have a 5 to 20% chance of non-progression by doing a biopsy. But SCRC was the location that was training people to do the biopsies for PGD about 15 years ago. And the West Coast, many people were sending people to our clinic in order to do so. So the people that are doing biopsies in my office are very, very well trained at doing it. And I rarely ever see an embryo that does not make it past the biopsy because of a poorly done biopsy. I don't encourage people to do it if they don't want to do it. But I also know what it's like to have had a miscarriage and not had a child in a pregnancy for 1.5 years afterwards. And knowing that I was putting a healthy embryo into my wife at that time that led to 2 healthy outcomes, I think means a lot. So I don't think it's for everyone, but if for someone that wants to know gender, for someone that wants to make sure that the embryo going in them doesn't have Down syndrome, I think it's encouraged. But again, I don't force anyone to do it. I think it's a personal decision. It's one of those things that I discuss with all of my patients, and if it's appropriate, I think it's valid to do. Sure, yes. So I'll answer the second part since I already forgot the first question. So the second question I'll re-summarize, but it's about the exchange of DNA between a surrogate mother and also the fetus and the baby. To the best of my knowledge, in every single way that I know, there is an exchange of blood flow that's helping the fetus grow and become a beautiful, healthy child at 9 months that's going to get delivered. But the DNA of everything that is going to the fetus and what the fetus turns out to become comes purely from the egg and the sperm. So every issue and every health complication or anything that's going on with the future genetics of the child comes from the mom and also the dad, and not from the surrogate. And the exchange of genetic material that you're concerned about between the surrogate and the fetus, I'm not aware of any of that ever occurring. Did you want to repeat your first question one more time? Okay, so the complications, it brought it back to me, thank you. The complications of what would happen to a surrogate during the IVF process is very, very minimal. The surrogate is going to be getting prepared for what we call an embryo transfer. Whether it's a frozen embryo transfer or a fresh embryo transfer, they're very, very similar, and they really mean nothing different to the surrogate. It's going to involve her taking birth control pills to kind of stop her cycle and kind of just making sure her body is at rest. And then it's going to involve a daily injection called Lupron that's going to keep her from ovulating on her own. And once she is on Lupron, there's going to be, we usually give estrogen pills. I know some of the clinics give estrogen injections or patches, but we give a pill that helps the lining of her uterus thicken and thicken, and once it's at the appropriate thickness, the embryo goes inside of her. I have not had any complications with any surrogates during this process. They are not doing the daily injections that an egg donor does. They're not going under anesthesia, they are not getting hyperstimulated. None of those things that potentially could happen to the person giving the eggs really occurs with the surrogate at all. But in terms of the insurance question, I think there's no option than to have insurance for the surrogate, because you never know what could happen during the pregnancy. During that first IVF process and putting the embryo in her, the chances of a complication are very, very, very low, and I don't think you're going to need to worry about it. But I know that for most of the agencies that we work with, it's mandated that there is special insurance for the surrogate's health. Did I answer the question? Yeah, sure. Yes. So most of our okay, the question was, do we do much with a natural cycle transfer into a surrogate? So most of our embryo transfers that occur for surrogates are medicated and controlled. It's because a lot of them are not local, so we can't bring them in as often as we would. Some of them are from smaller towns that don't have fertility centers that they can go in and know exactly the moment they're ovulating, so we know exactly 5 days later to put the embryo back in. So we generally do it with the medicated route, because once they're on the birth control and then on the Lupron and then on the estrogen, we get ultrasound results coming in from out of town or whether they're local, and we see when the lining is ready. If you are doing the medicated version, if the lining is already looking good, but they need an extra day or an extra 2 days to come into town for that reason, it's perfectly fine. It gives us some flexibility. So with surrogates, we are generally using the medicated route. Now, if a surrogate is local, we have a lot more flexibility. If someone has not done well with a medicated cycle, we have another option of doing the natural cycle. But we generally, to answer the question, use the medicated route. Yes? So the question is the difference between progesterone injection versus progesterone suppositories in terms of maybe success and also complications for the surrogate. So the progesterone, when putting an embryo in, so we're assuming when it's going into a surrogate, it's a completely artificial pregnancy, okay? Because it's obviously not coming from her own egg and she didn't release an egg. When you release your own egg, the capsule that releases that egg starts to produce progesterone. So since the surrogate didn't release the egg, we have to give progesterone artificially to the surrogate to help maintain the pregnancy and the lining. What we have the option of doing is either the injection or the suppositories. In our clinic, we do a combination of both. We do a progesterone oil injection along with the suppository, because even though the pharmaceutical companies that make the suppositories state that the blood levels are not going to be showing appropriate levels of progesterone with the suppository alone. We're not really 100% sure. And there was a time that we went only purely to the suppositories, and I think we noticed a difference in pregnancy rates, and that's why we went back to the combination of both. The progesterone injection, not only can you observe it and how it is in the bloodstream, so when we check a level, we know that we have the level we want to be. We feel that if we give that, the progesterone injection, you got a great level, you checked it on the blood test, you know it's adequate. Giving also the suppository vaginally, then we know has that local effect, which is vaginal, straight into the uterus, giving it exactly the progesterone it needs. So it's both. Now, the progesterone injection, I'm not going to lie, is uncomfortable for everyone, okay? We encourage people to do cold compresses before and warm compresses afterwards, rubbing it in so it doesn't get like a ball of oil into the body and becomes very painful. And it's something that we do for a few weeks and then we move on. We've had very, very few people that can't tolerate it. Everyone seems to be doing fine with it. And I think we just want to take a very conservative route. Intended parents are going through a lot to get to that point, and I think surrogates completely understand getting the suppository and getting the injection is probably going to give the best outcome, and they're more than willing to do it. So, no, there really aren't, and there's some data out there that has shown that even for preterm deliveries, right now some people go into preterm labor. Our maternal fetal medicine specialists that we work with, they encourage giving progesterone to patients to kind of calm the uterus down, so really no. Again, if we check the blood levels and they're sky high, we'll back off on either the vaginal or bring the levels of the injections down. So we would never give excessive amounts, but we just want it to be appropriate. Yes? Mm-hmm. So let's answer the first one, since I still remember it. So the question was, is there a problem if the surrogate does not have the same blood type? And the answer is no. Okay, we've seen this again and again, that there's not a problem with the blood type. We have a large number of patients that come from Asia to our office every day to use surrogates, and it's a huge concern to them. But it's not a concern. Medically, it's not a problem at all. You do not have to have the same blood type. It's perfectly fine. Yes, there's an exchange of blood flowing, but it's not a problem in terms of that. And as we know, that a child could get a blood type from a dad, not from the mom, and they have different blood types as well, so that's not an issue right there. In terms of the health and complications, I'm sorry, that was success rates. Yes. So now this time I didn't remember the second question. Thank you. So the success rates are not affected at all by blood type as well. So the sharing of the genetic material. So the question was, is there a difference of putting the embryo into the biological mom versus putting the embryo into a surrogate? And to be honest, no. If you have a proven, good, healthy uterus, you should be able to do well whether the embryo goes into the biological mom. The biological mom does not recognize that that embryo is hers. And that's why surrogacy is so successful. And that's why for many people that have difficulty conceiving, because of some uterine factor or unknown uterine factor, why surrogacy can be so successful, if not even more successful than into a biological mom that may have an issue with the uterus. Sure. Thank you. Thank you.